My name is Waffiyah Afridi. I'm a rheumatologist here in Farmers Branch, Texas. So before we begin our talk today, I just want to start with a short surah from the Quran. We're going to start with Surah Al-Ikhlas. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. And this translates as, say he is Allah the one and only, Allah the eternal refuge. He neither begets, nor is he born, nor is there to him any equivalent. Welcome tonight. Thank you everyone for joining us on this AMWPA sponsored talk on osteoporosis. Dr. Shehetaj Abdurrahim is going to be our presenter tonight. My name is Waffiyah Afridi. Like I had mentioned, I'm a rheumatologist here in Farmers Branch, Texas. I am also a member of the American Muslim Women Physicians Association. And before we get started, I just wanted to introduce AMWPA for those of us who haven't heard of this organization. They are a nonprofit organization that was founded in the year 2008 by a group of female Muslim physicians and dentists in the North Texas area. They consist of Muslim physicians, dentists, and allied health professionals. And the goal of this organization is to promote preventative medicine and education to the Muslim community here. The vision of AMWPA is to promote health, welfare, and education for women. And we just wanted to mention that they were quite active during the active phases of the COVID pandemic in educating our community and providing masks throughout the Metroplex. They were also able to provide meals for frontline workers and offered merit, and they routinely offer merit awards to Muslim female students going into healthcare, especially into medicine. Tonight's talk is on osteoporosis, and we have Dr. Shehetaj Abdurrahim with us here tonight. She is currently an internist working at Texas Health Physicians Group, but prior to that, she completed her internal medicine residency at the University of Illinois College of Medicine in Urbana-Champaign, after which she went on to become staff physician at the VA hospital in Dallas, where she worked for a number of years. In 2003, she joined Texas Health Physicians Group, and she currently works there in their internal medicine department. She's also a preceptor for the UT Southwestern PA program. She's also a member of the Fellow of American College of Physicians, and I'm delighted to introduce her today to educate us about osteoporosis. Dr. Shehetaj.
Thank you, Dr.
All yours.
Thank you, Dr. Waffiyah, for that introduction. I wanted to extend my thanks to the AMWPA as well for its tireless organizers who made this happen. And good evening to all those who have decided to participate this evening with us. And so let's begin. You see that I've got the Golden Gate Bridge in the background. No, I'm not in California. I'm in Dallas presenting this. And I chose this background because not only is it beautiful, but I cannot help marvel at the extraordinary engineering skills that involved placing two strong steel beams and its stresses to hold up a suspension bridge across a wide span of water. And I think it is much like our own skeletal framework made up of several types of bones, holding us all together to stand up tall. We all agree that healthy bones provide the body with the framework that allows us to move and protect us from injuries. Bone health is critically important to overall health and quality of life. Osteoporosis, a bone disease, is the most important cause of fractures in the elderly, which not only impairs the mobility, but also often becomes a chronic burden on the individual as well as the society. Unfortunately, bone health appears to be in trouble and is only going to get worse as the population ages. A staggering 1.5 million each year suffer from osteoporotic-related fractures. The biggest problem is the lack of awareness of bone disease, both the public as well as the healthcare professionals, many of whom do not understand the magnitude of this problem, let alone the ways in which the disease can be prevented and treated. And what is more concerning is that there's a large gap between what has been learned and what is applied by, again, both the healthcare providers as well as the general public. Many fracture victims become isolated, they become depressed as the fears of falls and additional fractures paralyzes them. So together, let's make some improvements in bone health by applying in a timely manner which is already known and what we are about to learn today, that is how to prevent, which is the main focus of today's discussion, but also to assess, detect, diagnose, and also treat osteoporosis. So our agenda today is, or this evening is, we're going to learn about osteoporosis. What is this? What are the signs and symptoms associated with osteoporosis, and how do we prevent and how do we treat? So how do you define osteoporosis? Simply defined, it is actually a bone disease that makes the bones weak, leading to structural fragility. This increases the risk of fractures, which is the broken bones. What you're seeing right now is pictures of a normal bone as well as osteoporotic bone. Now, the hip and spine bones have large quantities of what we call a trabecular bone, which has this spongy, lace-like or lattice work of bone inside. And this tends to lose density, resulting in weakening of bones, osteoporosis, and increasing a risk of fracture. Now, osteoporosis is a serious problem. It is typically a very silent disease because you do not have symptoms and you may not know that you have the disease until you break a bone. It is a major cause of fractures in postmenopausal women and also in older men. This slide, along with the next slide, alludes to the very dismal statistics. 10 million of Americans have osteoporosis, majority of those are women. And this number is only going to get worse as baby boomers age. Fractures can happen at any age, but often, fractures can happen in any bones, but most often the spine, the wrist and the hip are the ones that are involved. And this then causes chronic pain, deformity, depression, disability, and even death. Plus, half the people who break the hip never regain the ability to walk without assistance, and quarter need long-term care. The majority of people over 65 have not been screened and don't even know that they have osteoporosis. And studies have shown that physicians frequently fail to diagnose and treat osteoporosis, even in elderly patients who have suffered a fracture. So I think the healthcare professionals definitely need to do a better job of screening. People tend to think that bones are static, that they are unchanging, that they are inanimate object. But bone is actually living tissue. Specialized cells in your body called osteoclasts and osteoblasts are busy destroying bits of bones and replacing them with new ones. Most of the treatments that we use in osteoporosis targets bone building or reduces breakdown of bones, thus preventing fracture. And what you see in the next slide is, just like everything else, our bones also age when we get older. It is not, as we age, it's perhaps normal to notice small changes. We see a few more wrinkles, a little bit of gray hair, but most of us don't realize that the effect of aging that has on our skeletal systems. The body naturally removes old bone and replaces with new ones. When you're young, bone is replaced much more quickly than it's lost. This is when you're actually building strong and denser bones. Around about age 30, people reach their peak bone mass. After reaching the peak bone mass, your body replaces as much as it loses, but for a while, but around about 40 years old, less bone is being replaced. And this causes the bones to become thinner, weaker, and increasing the risk of osteoporosis. So who needs screening? Generally women over 65 or older, also men over 70, or if you've had x-rays that suggest low bone density or previous fractures, presence of risk factors for low bone density, or all patients who need screening. So what are those risk factors? Some bone thinning actually occurs with age, but bone mass largely is inherited. Now, there are some risk factors that you cannot change and others that you may be able to change. For many women, the disease actually begins to develop a year or two before menopause. Even though osteoporosis can occur at any age, the risk of developing the disease increases as you get older. So as you age, the bone loss happens to be more quickly, and new bone growth is slower. Over time, the bones can weaken and your risk of osteoporosis increases. Researchers are finding out that osteoporosis and fracture increases if one of your parents has the history of osteoporosis or hip fracture. Obviously, the disease affects women and men of all races and ethnic groups. White and Asian women are at higher risk. Frail, slender, thin-boned women and men are at higher risk to develop osteoporosis. And there are some medications which are used in long-term diseases which are more likely to develop also bone loss and osteoporosis. Some of the examples are steroids or glucocorticoids that are used for asthma, some rheumatological conditions, medications that treat seizure disorders, medications that are used to treat breast and prostate cancer, and also the medicines that you use to suppress your acid. That can also increase your risk. Certain antidepressants and medicines used for anxiety can do that. And so please, when you go to see your doctor, always review the medications and find out if any of these medicines that you're taking can affect your bone health. Chronic heavy smoking or drinking is also a high risk factor. It's the low levels of estrogens in women after menopause. Men with conditions that can lower their testosterone levels can also increase the risk of osteoporosis. Beginning in childhood and old age, a diet low in calcium and vitamin D can increase your risk of osteoporosis and fractures. Excessive dieting or poor protein intake also increases your risk. A healthy lifestyle obviously can be important for keeping bones strong. So low levels of physical activity and prolonged periods of inactivity can contribute an increased rate of bone loss. They also leave you, of course, in poor physical conditions, which increase your risk of falling and breaking a bone. There are other medical conditions, some endocrine, hormonal disease, gastrointestinal diseases, types of cancers also increases your risk of osteoporosis. So let's talk about the symptoms. How do you know that you have osteoporosis? By and large, osteoporosis is, again, like I mentioned before, a silent disease, because typically there are no symptoms unless you break a bone. Symptoms of vertebral fractures can include back pain, loss of height, or spine malformations, such as stooped or hunch posture. The bones that get affected by osteoporosis become so fragile that fractures result spontaneously as a result of minor faults, like when you're standing at a standing height. That normally would not cause a break in healthy bones. Normal stress as bending, coughing, lifting can all cause your bones to break if they are weak. How does one work up, or how does one diagnose? The doctor will perform a physical exam first, and what he's looking or she's looking for is, have you lost height? What's your weight like? What's your change in posture? How's your balance? And how do you walk? The way you walk also can give us an idea. Muscle strength, such as the ability to stand from a sitting position without using your arms. So in addition, your doctor will also order some labs, some basic ones, and also determine the levels of minerals and vitamin deficiency, thyroid disorders, and also other secondary conditions. Dexa scan, or the bone density scan, it's a kind of a specialized kind of X-ray used to measure how strong your bones are. With this test, it is now possible not only to screen and detect osteoporosis, but also monitor effectiveness of ongoing treatments for this disease. And also, it helps us to intervene much before a fracture occurs. After the test is complete, your doctor will give you a T-score that speaks to the condition of your bone. This score helps the doctors compare your bone density to the results of an average bone density of a young, healthy person. And also, sometimes they compare the average bone density of other people of your own age, sex, or race. Here's a picture of the bone density scanner. The test involves no discomfort, there's no injections, no special preparations. It usually takes only about 5 to 10 minutes. And I do want to inform you all that the Dexa screening is offered or provided during a visits to the clinic organized by the AMWPA. So please make use of it and get screened. The treatment, the goals of treating osteoporosis are to slow or stop bone loss and also to prevent fractures. An important part of treating osteoporosis is eating a healthy and a proper balanced diet, which includes plenty of fruit and vegetables. It involves lifestyle changes, exercises, medications, fall preventions to prevent fractures, and also treating any secondary underlying causes. Let me talk a little bit about calcium. Calcium and vitamin D are the most important nutrients for preventing osteoporosis and helping bones reach peak bone mass. Calcium is found naturally in some foods and sometimes is added to other foods. 99% of whatever calcium that you have in your body is stored in the bones and the teeth. It is this mineral that actually makes them hard and strong. So the amount of calcium that is needed for healthy bones is different by age. So the National Institutes of Health suggests that adults between 19 to 50 years old take about 1,000 milligrams of calcium every day. Adult men 51 to 70 take about 1,000 milligrams. Adult women 51 to 70, you should have at least 1,200 milligrams of calcium every day. And of course, adults, whether women or men above 71, again, it's the same amount, 1,200 milligrams of calcium. And the best way to get calcium is to eat a variety of healthy foods from all sorts of different food groups. Dairy products include milk, yogurt, and cheese. These have the highest calcium content. So if you take a cup of milk or 8 ounces of milk, it roughly gives you about 300 milligrams of calcium. If the calcium content is the same, whether you consume skim milk or low-fat milk or even 1% milk. Now, other dark green leafy vegetables also are other excellent sources of calcium. Broccoli, kale, collards are all good sources too, especially when eaten raw or lightly steamed, because boiling vegetables can take much of the minerals out of them. A serving of canned salmon or sardines has, again, about 200 milligrams of calcium. It's usually found in the soft bones of the fish. And look for cereals that are fortified with minerals, including calcium. Besides cereals, calcium is sometimes added to fruit juices now, and soy and rice beverages and tofu. So read the labels, find out if food items contain added calcium. The US Department of Agriculture recommends that everyone aged 9 and older eat 3 servings of food from the dairy group per day. So what is a serving? A serving of dairy would be equal to maybe a cup of milk or a cup of yogurt, or 1.5 ounces of natural cheese like the cheddar cheese, or you can have any 2 ounces of a processed cheese. Calcium is, again, best absorbed through the foods that we eat and the beverages we drink. For most healthy patients, it's important to eat a well-balanced diet instead of relying on supplements alone. For those who cannot get enough calcium, taking a daily calcium supplement may be necessary, especially people who have lactose intolerance or they have some sort of a gastrointestinal illnesses, which may prevent the absorption of calcium. And they cannot get that just from the diet alone. So those, or again, those who follow vegan diet or consume large amounts of protein and sodium may not be able to get enough calcium. So let's talk about what type of calcium is preferred or should you take. So again, the amount of calcium the body will absorb from supplements depends on the form of calcium in the supplement, how well the calcium dissolves in the intestines, the stomach, and the amount of calcium in the body. So the 2 most common sources of calcium or products of calcium are the calcium carbonate and the calcium citrate. Calcium carbonate supplements dissolve better in acidic environments, so they should be taken with meals. Calcium citrate supplements can be taken any time because they don't really need an acid environment to dissolve. For this reason, people who might have problems absorbing medications should consider using citrate, calcium citrate instead of calcium carbonate. And this would also include those who take medications to decrease the acidity in their stomach, like over-the-counter acid reflux medication or prescription heartburn medications. Also, those who have gastric bypass surgeries, or perhaps even those 65 and older would benefit from calcium citrate instead of calcium carbonate. There are other forms of calcium. You would see supplements like calcium gluconate, lactate, or phosphate. All those are available, but they generally contain less absorbable calcium. So also keep in mind, the higher the calcium dose, the less it's going to be absorbed, which means for the maximum absorption, no more than 500 milligrams of calcium should be taken as a single dose. If you need more than 500, take the dose at least 4 to 6 hours apart. Now, we often mention not only calcium, but also vitamin D in the treatment of prevention of osteoporosis and also for good bone health. So what is vitamin D? Vitamin D is an oil-soluble vitamin that has several important functions. One, it helps absorb calcium and phosphorus from the intestines. It suppresses certain hormones that break down the bone, like a parathyroid hormone, and therefore helps the calcium and the phosphate levels in the blood normal. Thereby, it promotes the bone health. So where do you get vitamin D? What are the sources of vitamin D? So let's talk about the natural source of vitamin D. It is made in the skin under the influence of sunlight. The amount of sunlight needed to make or synthesize adequate amounts of vitamin D varies with season. It varies with skin color, the time of the day, and it varies also with the person's age or any underlying medical issues. So vitamin D production in the skin decreases with age. In addition, people who have darker skin need more sun exposure to produce adequate amounts. Foods are another important source of vitamin D. Vitamin D is present in fatty fish, cod liver oil, and to a lesser extent, egg yolk. And in this country, commercially fortified milk is the largest source of vitamin D. Milk is fortified with, I think, 100 international units of vitamin D per 1 cup. So for example, if you didn't drink 2 cups of milk every day, you get about 200 units of vitamin D. So what are the potential complications of having low vitamin D or vitamin D deficiency? Now, the most serious complication, of course, is your calcium is going to be low and your phosphate is going to be low. But these complications have become less and less common over time because, again, like I said, most of the food and drinks are all fortified with vitamin D nowadays. What is more important and common is what we call as a subclinical vitamin D deficiency or vitamin D insufficiency, which is defined as having a vitamin D that's lower than the normal vitamin D level and which has no visible signs or symptoms. Thus, identifying and treating vitamin D insufficiency or deficiency is important to maintain bone strength. So how does one diagnose vitamin D deficiency? It can be diagnosed with a blood test called 25-hydroxy vitamin D. And of course, the National Academy of Medicine for Adults defines a normal value of this vitamin D to be greater than or equal to 20. Vitamin D insufficiency is defined as having anywhere between 12 to 20. And then vitamin D deficiencies, of course, anything that's less or equal to 12. Can too much vitamin D cause problems? Yes, when if patients have, let's say, levels of greater than 100 and who also consume large amounts or substantial amounts of calcium, can have complications, especially with high calciums and kidney stone, propensity to form kidney stones. Now, most experts will agree that levels lower than 20 are suboptimal for bone health. So who needs vitamin D testing? Do all of us need it? Does everyone need to get tested? The answer is no. Testing for vitamin D deficiency or insufficiency is not recommended for everybody. And it may be advised for people who are, let's say, homebound or in long-term facilities, like the nursing homes, or for persons who have medical conditions that interfere with vitamin D absorption. Of course, for anyone with osteoporosis or past history of fractures or low trauma fractures, especially a fracture that happens after a 4 from standing. Or if a patient has low blood calcium or phosphate, you want to check the vitamin D levels. So how do you treat vitamin D deficiency or insufficiency? And obviously you treat it with vitamin D supplements. The 2 common formulas or available forms of vitamin D that you can get over the counter, or no, the prescription is, of course, the ergocalciferol, which is your vitamin D2, and cholecalciferol, which is vitamin D3. Now, most experts suggest vitamin D3 possible rather than vitamin D2. So whenever you get a chance, please reach for the vitamin D3, only because vitamin D3 may raise the vitamin D levels more effectively. The dosing, of course, the recommended dose of vitamin D depends on the nature of and the severity of the vitamin D deficiency. So in people who are truly deficient, like for example, if their numbers are less than 12, you want to treat them with 50,000 of ergocalciferol, either once or twice a week. And you would do this for 6 to 8 weeks, followed by about 800 to 1,000 units daily thereafter. In patients or in people whose vitamin D is between 12 to 20, which is your insufficiency, the treatment usually includes 800 to 1,000 international units. And once the normal level is achieved, continue with 800 per day. And in people whose levels about 20 to 30, treatment with 600 to 800 units is sufficient. Again, this should be able to maintain the target range. Though calcium and vitamin D is very essential for bone health, don't forget that proteins are also needed to strengthen your bones and muscles. So a good source of protein is meat. You can get it from egg white, and also plant-based tofu are also good sources of protein. So exercise is an important part of osteoporosis treatment and prevention. Now, research shows that physical activities for bone health include strength training or resistance training, walking, jogging, jumping, swimming. They're all excellent exercises. Moderate exercise can be integrated into your daily routine with activities such as brisk walking, like 3 miles per hour, yard working, dancing. They're all considered as moderate exercise. Now, usually during a moderate exercise, you should be able to carry on a conversation with your buddy or friend without being overly short of breath. Then you know you're actually walking at a pace that is recommended. Resistance training is an exercise that's designed to increase muscle strength and includes lifting weights and using exercise bands. And it should be performed at least twice a week and with at least 48 hours of rest in between sessions. And of course, don't ever forget the stretching exercise. It improves flexibility and also prevents.
Do
you know how many people from my class have already died?
Now, exercise doesn't have to be continuous to produce health benefits. You can actually break it up.
That's what's a big class. Very classic
3 or 4 minute sessions per.
ऐसा मत सोचा कर देखा करो.
Physical activity guidelines recommend that you get at least 150 to 300 minutes of moderate exercise, moderate intensity exercise per week. And this, of course, this recommendation is in addition to routine, lightweight activities of daily living, like cooking, casual walking, shopping, etc. Now, I'm not sure if I can agree with the experts saying cooking is a low intensity, because, good Lord, if I just think of cooking as an activity, then I can break out a good, decent amount of sweat. That's, I think, is a good workout by itself. Now, something you need to do and remember all the time is always sit up straight. Perform specific exercises to strengthen and support your back that helps your spine and helps improve your posture. And perform exercise to strengthen your abdominal muscles and also to expand your chest muscles. I cannot stress the importance of improving leg strength to help reduce falls. As shown in this slide, you can certainly do modified squats using a chair to support yourself. Make sure the chair doesn't have any wheels and is firmly planted on the floor. This is a simple exercise I teach my patients to maintain a good posture, whether you're sitting or standing. This is called the W exercise. And all you do is you just raise your arm, pull your arms backwards, squeeze your shoulder blades, and hold for 3 seconds and repeat. And don't forget to breathe. And this actually helps quite a bit. Fractures take away your independence. So taking steps to prevent falls helps prevent fractures. To prevent falls from outdoors, use a cane, use a walker, use shoes that have thin non-slip soles, stop at curbs and check the height before stepping up or down. Now indoors, make sure you keep your rooms free of clutter, especially on the floors. Use a plastic or carpet runners on slippery floors. Again, wear shoes, you can wear even shoes indoor that provide support and also have thin non-skid slip soles. Now, if you have a pet, be mindful that where they are to avoid tripping or tripping over them. Be sure that the stairs are well lit and have rails on both sides. Install grab bars on bathroom walls near the tub, the shower and toilet. Use a rubber bath mat or slip-proof seat in the shower or tub. Improve lighting in your home. Keep a cordless phone or cell phone with you so that you don't have to rush to the phone when it rings. In addition, if you fall, you can call for help. Consider having a personal emergency response system. You can use it to call for help if you fall. And additionally, please finally get your eyes checked. On the treatment front, a variety of drugs have been developed that improve bone health and reduce the incidence of fractures. Now, your doctor will determine your risk and discuss treatment options, and together you can decide what is the best treatment for you. And what do these medicines do? They reduce bone loss, they increase bone density, or at least keep it about the same and reduce your chances of fracture. Here's a list of some FDA approved medications, and of course you can glance at it at your leisure. Like I said, I'm going to go mostly into the prevention. So what is important? To recapitulate, getting calcium from food is preferred, good nutrition with recommended servings of protein, calcium, vitamin D is important. For patients who cannot tolerate dairy products or have other restrictions, add supplements. Calcium citrate is better absorbed and tolerated than calcium carbonate. Divide the calcium dose, exercise, get moving, know your risk, and of course, it's important to get screened. So here's some exercise that, and this, I get inspired by just looking at this gentleman, but I don't want you to go and grab this, weight bars immediately. Make sure any exercise that you do, you have to ease into it, make sure you're comfortable. Always get your doctor to say it's okay for you to start an exercise program. So I'm going to talk about a patient of mine who's giving me permission to share her story. She's an 86-year-old, very active, retired professor. She has a history of high blood pressure and diabetes. She was diagnosed with fracture of the thoracic spine about 5 years ago. And she, of course, lifted something that she shouldn't, and we're all familiar with this. And 3 years ago, she had another fracture involving the right hip. And this time she fell climbing down the stairs, carrying a laundry basket in one hand and books on the other. And fortunately, she didn't need surgery for this. If that wasn't enough, 6 months ago, she fell again, trying to dodge a friendly but perhaps an overly excited dog who was twice her size, leaving her with a fracture of the left hip. And this time, of course, she had to have a hip replaced. She's currently on recommended dose of calcium, vitamin D, and also she's taking medications to help with her bone density. I wanted to play this short clip, but I'm not sure if I can get back to this slide again. So I'm going to finish and then play this. So remember, prevention is better than cure. Get moving. Either if you don't use it, you're going to lose it. And also, finally, please log on to the www.amwpa.org for the recording of this lecture and to access more preventive medicine lectures. I'm coming back to this patient, and I hope I can get back to. So anyway, so in spite of having all this, what she did 3 months ago was she actually had the audacity to hike a 2-mile uphill trail of the Smoky Mountains. And she did very well. And that patient is none other than my mother. All right, so that's about all we have for today. So I'm going to hand it over to the moderator now.
Thank you, Dr. Abdurrahim. That's really inspiring to know that your
I
mom was
know.
able to hike up the Rocky Mountains. That's amazing. That's really inspiring to hear.
I did having all those fractures, like,
Right.
literally cataloging those fractures. But yeah, so in spite of, it is inspiring. And also you have to remember, it's never too late to improve your bone health, right? So prevention of bone disease begins at birth, and also it's a lifelong challenge.
Correct. Thank you so much. That was a very comprehensive and easy to understand talk about, osteoporosis, the causes of it, how we can prevent this, who are the people who need to worry about this and be screened for this. So it kind of encompasses, things from the healthcare perspective, as well as patients thinking about their own health. So we're going to open up the lecture now, or the talk now, to questions. We have a couple of questions in the chat, which we can start with. If anyone has any questions, feel free to type those into the chat, and Dr. Abdurrahim and myself will be happy to answer them. So the first one, Dr. Abdurrahim, I don't know if you want to answer this, is, does drinking caffeine hinder the absorption of calcium in the gut? Would you recommend taking your calcium dose together with your cup of coffee in the morning?
I don't know about that. I think if it's just a cup of coffee, I don't think you should get any major interference or interruption in the absorption.
Right.
So yeah, I would say, as long as it's a cup of coffee, I don't find that it's going to be of any issues at all.
Right. I agree with you. I think that small amounts of caffeine shouldn't impede the absorption of calcium from the gut. But if you are a heavy caffeine drinker or you are a smoker, then, it is recommended to kind of maybe take your calcium at a different time than you're taking your caffeine, only because, the gut microbiome changes with ingestion of those things. And sometimes the absorption is hindered. But I agree with you. If it's a small amount of caffeine, it really shouldn't make a difference. And then we had a question here about sunlight and vitamin D. So we all know that vitamin D basically, is created within our own body through an enzymatic process, but it begins with sun exposure. So do you want to tell us a little bit about that process and how important it is to get sunlight? And here in Texas, how much do we get enough sunlight?
Right.
Do we need more? Yeah.
Yeah. So first and foremost, let me make this very clear.
Yeah.
Sun exposure for extensive periods of time is never, ever recommended because of the increase in certain skin cancers. So I think the optimum amount of time that you can actually sit in the sun and, for vitamin D absorption is about, I would say, a good anywhere between 5 to 10 to 15 minutes. This is what I know. And Dr. Waffiyah, you can certainly add to this if you think it's the duration is a little bit more.
Sure. Yeah, for sure. We need sunlight exposure in order to, activate those enzymes in order to get active amounts of vitamin D within our body. So I would say, even though we live in Texas and it's a very high sun exposure state, like you mentioned, prolonged sun exposure is maybe never a good idea, or for sure wear your sunscreen and skin protection. But yes, we do need some, mild to moderate amounts of sunlight in order to get active doses of vitamin D. We have another question here about, is estrogen still recommended for osteoporosis? So I'm going to go ahead and answer that one. Estrogen is no longer considered the first line therapy for treatment of osteoporosis or prevention of osteoporosis. And that is because the Women's Health Initiative study found that high doses of estrogen progesterone combinations that were given to women, for managing their menopausal symptoms or postmenopause led to increased risk or increased incidence in breast cancer, in coronary artery disease, in developing strokes, in developing blood clots. So if a patient is on estrogen for another reason, meaning they are on it for, say, menopausal hot flashes, or they have another indication, it is okay to continue that as their bone preserving treatment, but it's no longer considered the first line. If there's a reason that we can go without the estrogen, then we would for sure consider other medications in order to prevent or slow down known osteoporosis progression. Another question that we have here is, should we take calcium and vitamin D if a patient has a history of kidney stones? Dr. Abdurrahim, do you want to speak to that a little bit maybe?
Yeah, like I said, you know, in these patients, I would like to, of course, I think taking calcium and vitamin D is certainly not a contraindication when you have calcium stones, but also bear in mind, like I said, excess amounts when your vitamin D reaches 100 with excess amounts of calcium, that obviously also adds to the complications and increase propensity for calcium or kidney stone formation.
Correct, exactly, yeah. So we have another question here about, does sunscreen affect vitamin D synthesis? So I think it's maybe important to know that sunscreen is basically blocking the UVB rays in the sun, and UVA rays are actually what is, and correct me if I'm wrong, I might be mixing this up, but what I remember is that UVA rays are the enzyme activating parts of the sunlight that we are getting in our skin that's helping us to activate vitamin D enzymes. So it shouldn't really affect the vitamin D activation on sunlight exposure. So it's always good to wear your sunscreen for so many different reasons, and you should be able to get your vitamin D activated as well. There's another question here about, are there parenteral forms of vitamin D?
Can you repeat that, please?
Yes. Are there any other forms of vitamin D, like parenteral forms of vitamin D?
I'm going to leave that up to you.
I do believe that there are some. They are not commonly used. And as we are talking about this, let me just confirm the information. I don't want to tell you something that isn't correct. We don't typically use it. It's not something that we recommend. So I'm just going to quickly look this up for you while we go to the next question. So we have a question here that in CKD4 and end-stage renal disease, which is the better medication for osteoporosis? So that's a great question. So in patients who have renal, renal disease, what can we use for them?
For 1200 milligrams of calcium, how much vitamin D do you need for it to get absorbed?
Thanks for that question. Okay, so I'm just gonna, I guess, answer the speaker's question first. 1200 milligrams of calcium. So you don't need per se calcium in order to absorb vitamin D. You need calcium and vitamin D together in order to have the building blocks for your osteoblasts to form bone. But your calcium absorption and your vitamin D absorption are kind of, separate, and you don't have to link them together. If you're wondering how much vitamin D you should take with 1200 milligrams of calcium, that would probably depend on what your current vitamin D levels are. If you, like Dr. Abdurrahim really, clearly put for us, if you're in the deficiency range versus in the insufficiency range, depending on what your serum vitamin D levels are, that would determine your daily dose of vitamin D. All right, so I'm going to go back to the chat question that we had here. What is the maximum duration of treatment? I'm going to assume you're asking for osteoporosis, the treatment of osteoporosis, right? Not calcium and vitamin D treatment. So it depends on the agent that you've chosen. When it comes to the anti-resorptive agents, what we call the bisphosphonates, typically the duration of treatment is 5 years. And at that point, depending on the patient's risk factors and their bone density, we sometimes do give the patients a drug holiday and continue to monitor their bone mineral density via a Dexa scan, and then make the decision to restart or to switch to another drug. If you are thinking about the other drugs like denosumab, which is also known as Prolia, Initially, we actually don't have data on the maximum duration of treatment. You can, at this point in time, use it indefinitely. There are some studies, though, looking at long-term effects, but as of now, you can use it indefinitely. When it comes to teriparatide, which is also known as Forteo, that has a maximum duration of, well, it used to have a maximum duration of 2 years. It had a black box label warning on it. That recently has also changed. And then there's another drug called Timolose, which is also a parathyroid hormone analog. So depending on the drug that you choose, that would kind of dictate the duration of treatment of the osteoporosis, and also depending on the other, risk factors a patient has. So if there are some modifiable risk factors, and if the bone density is increasing, you can always consider a drug holiday. If you are on a medication that has a time limit, like Forteo, for example, used to, then we do recommend starting an anti-resorptive agent right after stopping the teriparatide. So it really depends on what agent you're using. We have another question here about, is there any data that calcium and vitamin D supplements affect atherosclerosis or calcification of plaques?
Yeah.
Dr. Abdurrahim, do you want to speak to that?
Sure. Yeah, I know there has been some concerns, and I remember when we talk about calcium supplements in postmenopausal women, there was this concern that they're at high risk for heart attacks or coronary disease, specifically coronary atherosclerosis. I think the general consensus now is it is safe. As long as it's 1,200 milligrams, it's actually considered safe. Now, we don't have any data beyond that, but I think that's where the concern was, exceeding 1,200 milligrams per day. But anything less than that, I think it's still safe to, continue with your calcium supplements.
Right, exactly. Okay. Then we have here, after an insufficiency fracture, how soon do you want to start vitamin D and bisphosphonates? Do you do Dexa scan before starting the meds? So a Dexa scan is really used to diagnose osteoporosis in someone who hasn't had a fracture. So it's more of a screening tool. If once they have an insufficiency fracture, they are now categorized and labeled as having osteoporosis. So you don't necessarily have to do a Dexa scan before starting the medications, but if you want to have it as a baseline in order to continue to monitor how their bone density is doing throughout the duration of treatment, or if once they've completed treatment, you want to have something to kind of compare back to in order to determine if they should be on a drug holiday or not, then a Dexa scan for sure is important to do. So yes, you could definitely do that. And you can start the vitamin D as soon as, the fracture happens. They should probably, hopefully, have been on it even prior to that. When it comes to bisphosphonates, I think it also depends a little bit upon the type of fracture and the treatment. So if it's somebody who had a hip fracture and they had to go and get their hip replaced, and now they have a prosthetic, and their bone is now kind of healing around that prosthetic. So orthopedic, generally, they tend to wait a little while to allow the bone remodeling to start and happen around that prosthetic before we start, but there is no contraindication. I know of some orthopedic surgeons who actually will give 2 doses of Prolia perioperatively, which is denosumab, it's not the bisphosphonate, in order to promote integration of the prosthetic within the bone. So there really isn't a contraindication unless there's something else going on, but you can start it right away. All right, we have also a question here. I'm sorry, go ahead, Dr. Abdurrahim.
I was going to ask, I saw this bottle over the counter says 600 milligrams of calcium plus 20 micrograms of vitamin D. Is that something adequate? Or because if somebody's going to need to take 1,200 milligrams, then should they need more vitamin D?
So what exactly is, how many units is that? Do they give you any unit, or just is it in milligrams?
No, it just says 20 micrograms, actually. It didn't even say anything else. 20
micrograms is, I believe, I'm not sure how much of units that is, but if the calcium says 600, like I said, it should be 1,200, depending on the age of the patient, of course. But if you're anywhere between 50 to 70, post-menopause, obviously, then you need 1,200. So you take 600 in the morning and perhaps 46 hours or even 12 hours later, you can take the second dose of the 600. The vitamin D, I have to convert that from whatever measurements that they use to units for me to say precisely as to how much vitamin D is in that combination.
Right. So a lot of the time they will package the vitamin D and calcium together in order to make it easier for the patient to take one pill versus two pills to improve compliance and kind. So they don't need to be together for absorption, but they do it together to improve, the patient's getting both of the things together. But again, I'm not sure what the 20 micrograms would translate to. I just wanted to go back quickly to that other forms of vitamin D. Are there any parenteral forms? So there are liquid forms, so capsule forms, tablets. There used to be an intramuscular form of vitamin D, but that is very difficult to find in the US now. That's something that you'll find more in European countries, but there is no IV or IM form of vitamin D. I had heard of a sub-Q form of vitamin D at one point. I will try to find that, and if we can get that information, we'll ask AMWPA to make that available to you. We have some more questions down here. Oh, I'm sorry. Okay, thank you so much. We have somebody here who just mentioned that 50 micrograms of vitamin D is equivalent to 2,000 international units. So if you're 600 milligram calcium, 20 microgram vitamin D, I believe she said it was 20, right? Not 50?
I think she said 20. Yeah.
20, yeah.
Yeah,
so
it's 20, yeah.
it's 20, right? So if 50 is 2,000, then 25 will probably be 1,000. So if you take 2 of those tablets a day, you're getting about 2,000 international units a day, which is a good amount of vitamin D daily if you are in the insufficient or normal range just for maintenance. If you are vitamin D deficient, then you would definitely need more than that. Okay. Let's see if there's any other questions that we can take.
Waffiyah, I just have one.
Go ahead.
So a lot of my patients, when they come in, when we talk about treatment for osteoporosis, they get concerned and say, well, no, I don't want to take this because my dentist told me not to take it, or I'm afraid that I'm going to have fractures just because I'm taking the medication. So, and again, for all the participants, I want you to tell us, what kind of advice would you give these type of patients regarding this concern that they have, that they read in the news or, Google this type of information?
Right. So I believe, this concern for jaw osteonecrosis or having more, dental problems by taking this medicine for sure is there. And it is something that we definitely discuss with our patients prior to starting them on bisphosphonates. But like any medication, everything has a risk and a benefit. And the risk of developing ONJ is very, very small compared to the risk of developing a fracture. So what we do is in the office, we assess patients based on something called a Frax tool or a Frax risk assessment, which is an assessment of your 10-year risk of developing either a hip fracture or any kind of osteoporotic fracture. We only recommend treatment for people whose Frax scores are greater than 10 to 20%, depending on the year and the location, only because their risk of fracture at this point outweighs their risk of developing osteonecrosis of the jaw. So for sure, you might, having a side effect to a medication is a very plausible concern, and we've seen this, and that's why we discuss it. But your risk of developing a fracture or falling and breaking your hip with a minor injury is way higher than the ONJ. And the subsequent outcomes that, the morbidity and the mortality that we see in patients who have an osteoporotic hip fracture, a femoral neck fracture, or a vertebral fracture for that matter, really outweighs the risk of developing ONJ. So we do recommend that they bring their concerns to us. We do ask them at each visit if they've had any dental issues, if they're going in for any dental work. We definitely discuss with their dentist as well. If they need a root canal or some sort of bone graft, we hold their medication, we restart it later. But it's really a risk assessment and the patient has to be on board. Yes.
how long would you hold these medications for a dental procedure?
It depends on the procedure. I mean, if somebody's getting like a bone, graft in their jaw, you probably hold it longer. If they're just getting a root canal or a tooth taken out, you can probably hold it, for a less amount of time, depending also on the medicine. So if you're taking an oral bisphosphonate, that's something that you take once a week, versus if you're taking denosumab, that is a Q6 monthly injection. So holding your medication 1, 2, 3 weeks would clear that out of your system prior to having your dental procedure versus waiting 6 months if you're taking Prolia to have. So it depends on what you're on, what you're taking.
Okay, and also the duration of the medications also, increases the risk of the atypical fracture. It's not like within 2 years you're going to be having this type of fracture that you're concerned about. Isn't that
right? It is definitely, well, it depends also on the drug. So for example, teriparatide, which is a parathyroid hormone analog, it does not give much benefit beyond 2 years, and that's why they recommend switching over to something else. So if you've been on that for 2 years or longer, for sure you might have a greater chance of an atypical fracture versus if you were on, say, for example, a bisphosphonate for 5 years or for 3 years. So it depends on what they're taking. But yeah, I mean, with any medicine, there is a risk associated of side effects, and your risk of fracture needs to be way higher than your risk of side effect for us to recommend that for you. So we have another question here. Patients on hormonal therapy for breast cancer, when do you start treating for prevention of osteoporosis? So we actually start treating them right away. We would recommend the baseline Dexa, and if they are on hormonal therapy, we use it as an adjunct as soon as they start their hormonal therapy. And even once they're off of their hormonal therapy, sometimes some of their hormonal therapies last 5 years and then or 10 years and then they come off of it. We recommend continuing their osteoporosis therapy even beyond that. There's a big not miscommunication, but there's kind of a misunderstanding that once you're off of the hormonal therapy, you don't need to continue the osteoporosis prevention, but you actually do, because usually you're in a postmenopausal state at that point. So your postmenopausal state, kind of based on your other risk factors and your Frax score, will probably push you into requiring you to be on treatment for longer. So if they are osteopenic I guess a follow-up to that was if the patient is osteopenic at the beginning of their hormonal therapy for breast cancer, would you continue it? Yeah, I probably would continue it even once their hormonal therapy is completed, unless their bone mineral density, unless their Dexa score is completely normal, which it probably won't because they were osteopenic to begin with. I would recommend continuing it on. Yes. All right. Do we have any other questions for myself or Dr. Abdurrahim? I'm sorry, Abdurrahim. It looks like we got to most all of them.
okay?
Well, I guess if there aren't any more, Dr. Abdurrahim, thank you so much for your comprehensive talk today. It was a good refresher for myself, and I'm sure for all of the other attendees on today's call, and for our community, just for patients and their knowledge, and to kind of help people ask better questions when they come to their doctor, be more proactive.
I missed the first part of the talk. How often do you do the bone density? Is it every 2 years or every 3 years?
So I'll let you handle that question, Dr.
Sure. So it depends on the clinical risk factors. If we know somebody is osteopenic or they are osteoporotic, then we do tend to do a Dexa bone density scan yearly. If it is somebody who has, again, like, you could do a Frax score on them and see if they have a low risk, then you could probably get by doing one every 2 to 3 years. Sometimes, unfortunately, it's also dictated by the health plan, but generally, clinically speaking, based on their risk assessment, at least every year if they have known osteoporosis, and at least every 2 to 3 years if we are just screening them and they are in the osteopenic range.
I think the Frax score that you alluded to previously is a nice tool for the just general public to go online. And you don't have to have a bone density scan to actually use that Frax score. You can do it. Obviously, it's better if you have the bone density results, but I think they can certainly also look into that.
For sure, bring it to your clinician. They can help you with that. There are some clinical questions involved. So, but it's a very useful tool. I feel like it's very useful for our primary care physicians as well as our specialists.
So, I'm sorry, what would be the concern with the Pratt score? How low would it be for somebody to repeat it in a year's time?
So I think she had discussed about the Frax score. Like if you're, usually it gives you the risk, like it projects 10 years from now, what's your risk of having, let's say, a major osteoporotic fracture, or what's your risk of having a hip fracture? Now, if the score tells you that your major osteoporotic fracture risk is greater than 20%, or I think the hip fracture risk is greater than 3%, you're one of those patients who will need treatment. So that's what you're looking for in that kind of a score.
Right. Once you do the score, you don't have to continue to repeat the Frax score every year unless the clinical scenario changes. So unless, for example, the patient has now developed some sort of disease where they have to be on long-term steroids, right? So in that situation, their Frax score has now changed drastically. Right. But if their Frax score is low, it really dictates their risk. And then you decide on the yearly DEXA bone density versus the every 2 to 3 years versus doing it at a longer duration.
Okay, thank you very much.
Thank you.
Thank you, Dr. Waffiyah. Excellent.
Thank you, Dr. Abdurrahim. So we will definitely have this recording up on the AMWPA YouTube channel for anyone to kind of go back and listen to or to share with their family and friends. We appreciate everyone's participation today, for the excellent questions, and we appreciate AMWPA for providing us with this platform in order to, give this education to our community in the hopes of spreading awareness and preventative treatment for diseases that we can look into. Thank you so much, Dr. Abdurrahim, again, and good night, everybody.
Thank you, Dr. Waffiyah. Good night. Thank you.